listen only mode.
Hi everyone, we are back.
Hello.
I'm very excited to be here, and we want to thank you for the hiccup. We had quite a problem with Zoom, and so we were able to last minute, literally 7 minutes before we were supposed to go live, come up with another platform. So thank you for everybody's continued patience, and we are very excited to be here. I think we should give people a bit more grace, and I think everybody just needs a chance to kind of adjust. Would you agree with that?
Yes.
Yes.
Absolutely. Yep. We applied our process of care skills and assessed our needs and implemented new strategies. And we're now going to evaluate a new webinar platform. And we're just like, whoa.
Do you think I should just put this out on Facebook? Or
I think
yes.
I think
Do it? Okay. I do have an opening, so I will, when you guys are ready, I'm just gonna do this quickly on Facebook and just say. But see, my computer's not.
Anna Louise, where are you right now? It looks like that's not your typical room that you do these in. Where are you?
I'm in Niagara Falls, and I'm enjoying a 2-night stay with the love of my life. It's our 37th wedding anniversary, so we're here in Niagara Falls.
Wow. Congratulations.
It's actually pretty remote. Well, it's usually really busy. It's really pretty quiet here. So yeah, we arrived yesterday, and we're gonna like go and walk our feet off and be a tourist for today.
I had to get up early up at the cottage. Sorry, I've been relaxing here, so I wore like a nice light shirt to reflect the mood and attitude. So looking forward to enjoying talking with everybody and participating in my first view. Amazing platform, great organization, and thank you very much for the invite. I appreciate that.
And today we have Lorraine, which is so awesome. She's joining us today, as some of you may know her face from doing different courses at RDHU, and she's one of my colleagues that work with me with Aura Vital. So we're excited to have you. What have you been up to today, Lorraine?
Well, I went for a nice walk this morning before it got too hot, so that's always the first thing on my agenda. And just been, taking it slow today because I've been working many extra hours since we started back to work. So feeling good about it, but the extra hours I'm not too fond of, but it's only temporary. But really super excited to be on with you all today, and this is such a fabulous platform.
Thank you. And I know Kath and Beth right now are trying to handle and help out as many individuals that are trying to log in all aspects that way. I just have to respond to 2 emails that came in from the Aura Vital side. Just give me a second, and then we'll get started with the webinar. Is that okay, ladies and gentlemen?
We had one heck of a thunderstorm up here. I remember years back when we had a youth group, I was taking stuff out of the car and this thunder came, and I thought someone had shot a shotgun, and I ended up going face down into the mud. So last night I'm glad I was leaning over the dog to check and see if she was okay, and this clap of thunder came that just shook the house and scared the bejesus out of me. We had quite a lightning storm, and today I had to go down and bail out the paddle boat because it was full of water from what had happened. It was starting to sink. So looking forward to some professional time now with a great team.
Yeah, that should be a nice treat for you, and we'll keep you off of your job list for at least an hour.
Honey-do list, yes.
Yeah.
One of the things we're going to talk about in the webinar is the link with COVID and periodontal disease. And Lorraine, you found some articles, and Beth, I think you're going to share 1 or 2 of those articles with the group afterwards. But I think this is an exciting area for us to explore because it's, as I say, it's in our wheelhouse, and we can have an impact on assisting our patients to get them healthy so they're able to fight off COVID, I think, and perhaps help our medical professionals to assist people in hospital with some treatment that they may not be thinking about at the moment that could help to control their periodontal disease while they're under care.
Yeah, I know Joanne Jones had shared that webinar that was hosted by EMS, and I think maybe you also, Anna Louise, had mentioned that, but it's a fantastic webinar.
Yeah.
It is very valuable, and it's and you know, our clients have learned so much over the past several months that this is prime time for the topic we're going to talk about today. Launch of their interest has been piqued, their education has been developed, and you know, think of all the words that are now part of a lot of people's everyday language that it certainly hasn't been up until this time.
Mm-hmm.
Are we ready to go there, ladies?
Up to 23.
Oh, Kathleen, you're muted, hon. You guys are all watching us from home and everything else that way. You guys are really getting to see the truth of us trying to mitigate this. Sometimes it looks really easy and we come across really smooth, but behind the scenes, sometimes it's just a bunch of mixture. So we're doing our best. We're doing our best here to get it all going, but it's always been a lot of fun. And I look forward to these times of connecting with you ladies. And so for all of you that are listening, I know Kath will probably tell this to you anyway, but Dr. Hyland is my dad. So if you come across as some of the things looks I may give him, or the way I may kind of say his name, I either will call him Jim, sometimes I call him Dad, or Dr. Hyland. It depends on the situation I'm talking with, but I want to send that out as a disclosure that if I give him a funny look, it's because he's actually my dad too. So we kind of have this unique relationship.
If I'm called Jim, I'm in trouble. Okay.
I was thinking that today because you always refer to your dad as Jim.
Yeah.
And
yeah.
I saw the emails today and I'm like, it's good. Because I work with Aiden and I'm often, you know, sending him an email and then I'll say, love, Mom.
Well, I know my grandkids they called me Jim once or twice, and that's because I was ignoring them, and they knew Carrie always used that to get my attention. So it's a nice, it's cute.
He's trained them well.
Yeah, he knows when we're in the office that if I have called Dr. Hyland, and then if I say Jim, he's like, oh, I better pay attention because she's up to the ante. I have to listen to her now. I must give her a response.
Well, we love working with you guys. You're a great team. So we really are happy to have the three of you on here today as OraVital representatives, which is very exciting. I just created a little intro that I'll share with you. But really, like, you three are some of my most favorite people that I have in my circle, and I'm very, very pleased to have you in my circle. And I respect you all so much. Yeah, feeling the love. So we have Lorraine Gamacor, who is practicing clinically, but is also the clinical coach for OraVital. Lorraine has a passion for many things. One is her probiotics, besides her granddaughter. Probiotics, and she's done so much research and has put together some fabulous presentations for RDHU. So she's put together some articles. So if ever you're looking into probiotics, Lorraine is your go-to person. And she is also our soft tissue management trainer for Ontario. So thank you, Lorraine, for that. And last year, her and her partner, Val Petrie, had their first event in Toronto, and they brought up Dr. Bale and Dr. Doneen from the States, and they're the authors of the heart attack gene. They have the Bale-Doneen method. So Lorraine has a passion for the oral systemic connection and really focuses on the cardiac health. Carrie wears many hats besides being a wonderful mom. I see all your posts and you're always juggling family, work, and you're always smiling and seeming to have it together 95% of the time. And so Carrie does wonderful, she's practicing clinic practicing clinically as well in ortho, general. She even does, well, I should say even does ortho. That surprised me. I learned that about Carrie this week. But and again, has a passion for the oral systemic connection. She is the coaching director for North America for Ora Vital, and also a RDHU presenter, and also a quality assurance coach for Ontario dental hygienists. So thank you, Carrie, for being here. And then we have Dr. Jim Hyland, who, it amazes me too, because you're a CEO of Ora Vital and you're still practicing clinically, which is amazing. I don't know how you do it all. And what I love the most is that you're a huge advocate for dental hygienists and for preventive dentistry. So that was, you know, one of the first things that I learned about you when we were recording you for the Dental Hygiene Quarterly. You said that when you introduce yourself to your patients for the first time, you tell them that you are a doctor of dental surgery. There's the doctor who is all about healing and education, prevention, and then the surgery part is, you know, you're cutting gums and teeth and extracting teeth, and then you say you do both very well. And which doctor would you like me to be with you? And they always choose preventive. But to me, like, that was a very impactful thing that you said, because it really, it just changes the whole, like, it starts it off on a positive, and it really shows them that I'm here to help you. We're going to help prevent disease. And then you go on with your, you know, what I can do for the 2 hours that you're with me in my chair versus the other 8,458 hours that you're not here.
Exactly, yeah.
So important. So, you know, I love the way that you guys always use your analogies. You make things real, you make it understandable, practical. So again, thank you so much for being here. And you know, with the bacterial testing, it is essential. Like, it's a wonderful opportunity for us to really take a look at this and to learn what we can apply to our practice now to really change the messaging, to change how we're treating our clients. Because what we don't want to see is people going back to practice and doing the same thing that they always did. We have to take this pandemic and make it a positive and do something different to really, now is the time to make our clients healthy. So, you know, when we talk about microbiology testing, what type of tests are available?
You know, that is a really good question. And it's one that I get asked, and we get asked all the time. So there's different types of testing. There's like a phase contrast microscope that you can have in your operatory. There's a gram stain analysis, which is a slide you send in, and DNA. Have any of you guys ever done testing before or used any sort of thing?
I did the phase contrast microscope, and I loved it.
Yeah, it's pretty fascinating, isn't it? Because you can really, it's an interesting tool to use to engage with your clients, and the phase is awesome. And I thought that you had. And so with this action, it's nice. You take your plaque sample, you put it on a microscope, and within a few minutes, you literally can show your client their bacteria moving around. And to see, and it's very easy to see spirochetes and those sort of little corkscrew things moving around. It is one of the best tools to use to motivate people if they kind of get a bit squirmish. And given post-COVID now, we're really kind of dealing with it all. It's an awesome opportunity, chair side. And there are companies that will train you on reading slides, and it's an easy thing to add in. There's also, as with Ora Vital, we offer two types of testing. One is a gram stain analysis, which is neat because you can actually take samples from different areas and you get a site-specific report. So it'll say on your tongue, this is what's present. On your, in quad 1, quad 2, it's laid out that way. So you can really base your therapy. Lorraine and I, we use it a lot for our halitosis patients in that manner, or we have people that have concerns with implants. And so if you've got 4 implants that are failing and you want to know what's going on around them compared to the rest of the mouth, offices will use this technique to kind of get an idea of what is there. And so that technique's been around for a very long time. And then about 10 years ago, DNA testing came into play really on a big platform. And there are about 3 different companies that offer it. There are lots of them that are starting to come through the woodworks, but 3 main ones: Oral DNA, Hain Diagnostic, which is now formerly MicroBlink DX, and us with Ora Vitals. And we all have different sampling techniques, but we all are really targeting the high pathogenic red complex bacteria. We're looking at strep mutans, we're looking at yeast, we're looking at a wide variety of them. And the key thing with this whole types of testing is you really want to get a quantitative data to know how infected are people. Because you want to, just like you're doing your periodontal charting, your before and after, you want to know at what level were you actually able to reduce the microbiological burden on that client. Because for some people, they have a low grade infection for a long time, and those bugs are sitting there growing and growing and growing and growing. And later in the session today, Lorraine and I both have examples of people that you can see transitional biofilm from one family member to another, and they look almost identical. And that is absolutely crazy. And so there's lots of options. Another question we always get, especially when I'm lecturing on this, is coding. How do you code out? What are their options? And there are codes for ODA and ODHA. So the ODA code, we're from Ontario. We know there are people here that may be joining us later from the United States or from different provinces. But for Ontario, if you're working in a dental office, it's 04101, and then you're going to add your lab fee. If you're an ODHA and you're self-initiated, you're going to be potentially using code 300, 310, or 320. All of them, you want to add in a lab fee to cover that cost with it. And so it really is kind of an interesting option. And I see so many offices use it in many different ways.
Mm-hmm. That's awesome, Carrie. I think there's just so much still that's so unknown. Even myself, I'm just trying to get to know this a lot more. But how could we actually demonstrate the need or the value of testing?
I can answer that one, and
Yeah.
I'm going to actually share a story because I think we can learn best from stories. And this is actually a client of mine that I had seen for many, many years, and he'd had about a 5-year absence from coming into the clinic. And one of the first things he said was that he'd had a lot of family stresses and that he had neglected his home care and that he wanted to lose some weight and pay more attention to his oral health. So aside looking at all the risk factors, the ones that he had that were obvious, being overweight and having lots of stress, he also had high blood pressure, for which he was on medication for, but his blood pressure was still moderately high. His mother had had diabetes, and he had not been tested or diagnosed with, and he also had a history of heart disease in the family. So when I had seen him 5 years previously, he had about 30 bleeding points in his mouth overall. So when I started my assessment, I was probing just the first quadrant, and he had bleeding in almost every single probing area, just in that first quadrant on the buccal aspect. So I actually stopped the probing, and I took a soft pick to do a papillary bleeding score, and his papillary bleeding score was 3. So for those of you who've been using the papillary bleeding score, a 3 score means that there's bleeding in 75% of sites. So whenever I see really significant bleeding like that, there are 3 things that come forefront in my mind. Number 1 is that we want to have that discussion about the oral systemic connection and the impact of that to overall health. Number 2, we want to create a sense of urgency so that they're going to begin treatment right away. And number 3 is that we want to think about DNA testing so that we can understand what types of pathogens are contributing to that infection and what the overall burden is as well. So when you want to stop and show that value or demonstrate that value, you want to stop, show, and share. And for Glenn, I sat him up in the chair and I said, you know, I'm really concerned because you've got a really significant increase in bleeding, and we really need to understand what pathogens are contributing to your infection. So I would recommend that we do some DNA testing and, you know, explain that it may or may not be covered by insurance, but that I could go ahead and do that test if he was ready to proceed. And there was absolutely no hesitation. He was a highly motivated patient and, you know, went ahead right away. So will everyone accept treatment like that right away? No, we'll always have those patients who will want to have a predetermination and see what's covered. But I think now more than ever, we need to really get this message across, because this new knowledge about oral pathogens and how they can increase the COVID-19 complications. And Jim, I think you wanted to add a little something to that.
Well, you're right. And Lorraine, what you're saying as well is if you can't show the patient what's in it for me, they're not as likely to want to do testing or any treatment that you're going to participate in. And so mentioning the oral systemic lymph, demonstrating that they have gum disease with bleeding on probing, and especially with papillary bleeding score. And don't forget to ask them if they're kissable when they're bleeding a lot, because that motivates people significantly. But you better be able to stop the bleeding if you're going to mention it. But then you can bring COVID in. And, you know, Tom, a little while ago, was talking one of our webinars, and he said, and you alluded to this, Kathleen, we've had a captive audience for 4 months now, hearing about how important testing is every single day. But they're thinking DNA testing for virus. But if we can bring in the disease factor, the oral systemic link, and start to mention COVID now. And so, you know, what we're seeing is all sorts of articles saying high bacterial loads of oral pathogens increase the complications for COVID. And is it related, and why? And it starts with simple things. 80% of our patients' tissues bleed when they're touched, and that's just unacceptable. It's not normal. It's never normal to bleed unless you're menstruating or you're having a baby. If you're bleeding, you have gum disease, you have a wound, you have an infection, you have cancer, you've got a blood dyscrasia, you're very sick, and if you're seeing your physician, you're going to be referred out for care to make sure the bleeding stops, and then reassessed afterwards. And in dentistry, we haven't done that. We haven't taken bleeding as a serious issue. So it doesn't matter whether it's gingivitis or periodontal disease. And then if you take a look at COVID, we're seeing that the patients that are sick have comorbidities, in particular cardiovascular disease, diabetes. Does that sound a little bit like periodontal disease and the impact periodontal disease has on those diseases as well? And you mentioned Bale-Donine, where they said high-risk pathogens cause atherosclerosis. So in the when we take a look at how they interact, the bacteria and virus both affect something called the ACE2 receptor cells on the nasal, in the nasal area and the nasopharyngeal area. And those receptors start the release of cytokines, interleukins 2, 6, 10, and a cascade of events that creates inflammation. And what they're finding is the patients that have the diabetes, the heart disease, the obstructive lung disease also have a concomitant periodontal infection at the same time. And how do they know that? Well, in a virological infection, you don't get neutrophils. And what they're finding is they have high neutrophils. Neutrophils are a response to bacteria. They're also seeing low leukocytes. And the leukocytes can only be low if something happened prior to COVID that caused them to be low. What is it? It's either that they've been stretched out and overused fighting an infection, or that there's a concurrent bacterial infection at the same time. And now if you have patients with comorbidities and periodontal disease, and then you add the load of the virus on top of it, it accelerates the rate of the interaction among them all. And so that's why periodontal health is extremely important for our patients. And that's something you can bring up in talking in the health history. It's not just bleeding, it's not just kissing, it's not just transmission to your family, it's not just bone loss. You're at risk if you get COVID. And this may be enough to have people interact a little differently with you. So Beth, you're putting that paper up, I think, in that link for us on things. And as I mentioned, this is our wheelhouse. So if I can quote what Victoria says, she says, we recommend that poor oral hygiene be considered a risk for COVID-19 complications, particularly in patients predisposed to altered biofilms due to diabetes, hypertension, or cardiovascular disease. How do you determine that? Clinical signs and symptoms and bacterial testing. And this is interesting. The other thing they found is that the therapies they're applying are antiviral therapies and antibiotic therapies at the same time. Why the antibiotics? Both for the pneumonias, but also to treat the periodontal disease that's there. And when they combine the two, they get far better results. So I think there is this type of link. I think we can make a difference for a patient's health. And it's not the therapies we provide, it's how you present this, it's how enthusiastic you are, how passionate, how knowledgeable you are about it. And that's what will get patients to say yes to what you want to do. So COVID's important for us to discuss with patients now.
Right. So who can perform the DNA sampling, and like how do you select your patients for that?
Usually it's the hygienist who does the testing, although there's many dentists who also will do it. And I love that. I love to see that dentists are passionate about perio and very involved in the perio program. I think that is key for hygienists and doctors to be on the same page. Level 2 assistance in certain provinces. I was just actually speaking with an assistant from Alberta. Now they seem to have a lot more abilities than the level 2 assistants here, but they actually have a probing module that they can do in their training. So if they can probe, then they'll be able to also do the DNA analysis. And many practices are using microbiology testing as a component of their new patient exam, which I think is super valuable because it's going to give you that much more information about the baseline and where they are. Definitely, it is ideal to be done before an active therapy appointment, but for the most part, most practices are implementing the testing with their existing patients, their existing 3-month perio patients. So maybe there's a patient that hasn't responded well to treatment. Maybe there's someone who's had increased bleeding. And then there's also those patients who maybe don't have bleeding, but you've seen a slow progression of bone loss over time. And the new AAP guidelines are really going to help us to recognize that, because we're going to be much more focused on the bone and the clinical attachment level.
Okay, so if I have an adult and we're going to do DNA testing, do I need to think about, you kind of alluded to, I need to like think and rack my brain about the rest of the family members?
Yeah, you do. I think that the best way to handle it is to have people treat their infected spouses at the same time is the most ideal situation to screen people, to understand what's going on. That is a huge asset to all that we do. And we're very fortunate, often we can see that, and you can see between grandparents and children. And that's why when you know grandparents are looking after their kids, part of my conversation when they're in my chair is not just about what they can do. It's like, how can you prevent your grandkids from having this problem? And what should you be sharing? What shouldn't you be sharing? This is all part of this biofilm makeup for sure. Lorraine, did you want to add something to that? Sorry if I cut you off, I apologize.
No, I was just going to say, one of the conversations I have with a lot of moms or parents, you know, they see their child soother fall on the floor and they pick that soother up and they pop that in their mouth. So they're sharing their pathogens with their babes.
I know, and I think that this might be a good time. Lorraine and I both pulled out 2 different patients that we want to share with you, and they were family members. And so if you give me a second here, I'm just going to share my screen, and let's just see. I'm going to choose this and show my screen here. So what you're going to see for just a second is you will see some gram stain reports. So this is one of the options we have with regards to testing. And when you look at these 2 reports, I know for a lot of us that are looking at it for the first time, it's like, I don't know what I'm looking at, Carrie, but what you're going to see is if you look at the left one and the right one, you're going to see similarities. The difference between these 2 reports was 35 years. They were taken on the exact same day. One was a daughter and one was the mother. And they both were suffering from the same concern. And so when you start looking down family lines and you see this at a 9-year-old child to have this much infection already in this bacterial matrix and load that they're carrying, you know, this is also why we have that perio pathogenic makeup and the concerns with cardiovascular disease and diabetes and all those things. So you are going to see similarities, and that's why, you know, you see one family that has cavities, the next one has cavities, and they say, oh, it's my genetics, I have soft teeth. No, you have the same biofilm makeup, you've got the same lifestyles, the same kinds of foods and things that you choose from. Lorraine, why don't you talk about this one?
Oh yeah.
Yeah, so, and this is an actual husband and wife. And so, first of all, just to mention, the pathogens that we're testing for are the high-risk pathogens, PG, TD, TF, AA, moderate risk, FN, PM, looking at Candida and Strep mutans. So the top one was the wife, and the lower one was the husband. So you can see there's such a huge similarity. The only difference being high levels of AA in the gentleman that had the heart attack. And at our practice, we treat a lot of spouses together. so that we're all starting, you know, at the same healthier page after treatment with Orovital and their ongoing care. And the other thing to think about too is that if a patient, one of the spouses has had treatment and the other one has not, and you're starting to see a regression or, you know, increase in bleeding, you need to also ask questions about that spouse. Is that spouse coming to care regularly? Are they a patient at your practice or another practice? And if they have this degree of infection, then they're going to be giving that reinfection or transfer of pathogens to the other person.
And I think that's, sorry, go ahead.
Go ahead.
I was going to say, I think that's a huge deal to think about, is that transferability. And, you know, it's one of those things that we do have to think about, spouses, and that reinfection. You know, we think just because we did something, it's never going to come back. We are at risk all the time. If you get a new boyfriend, you get a new pet. Pets are infected. We've got pet biofilm that shows like severe infection, and it's like people have said to me, I think my pet's reinfecting me, and I was like, oh, come on, you got to be crazy. And then someone sent in a report, and I was like, okay, back it up. You are absolutely right. Your pathogen makeup and your pets are almost identical. It's crazy. It does happen. So we have to have healthy mouths to save, like, save ourselves, to save our family, and, you know, to put us at less risk of any other things. Go ahead, Jim.
Yeah. Well, if you think of it, I've had good friends, and on one side, both parents died of Alzheimer's at a very young age. I got to see my friend, and they had significant bleeding and no bone loss. Well, what we know is with Alzheimer's that 93.7% of all the patients have one of 5 oral spirochetes in the brain. And we know oral spirochetes cause syphilis. We know, spirochetes cause syphilis. Spirochetes cause Lyme disease. And in both of those cases, we would take it very seriously if we were exposed to those bacteria. It'd be like, how soon can I get an antibiotic? Like today. And Carrie, your son had a tick bite, and it was within 12 hours we had an antibiotic. So I started communicating with her about my concern was the risk that their mom and dad, in kissing her as an infant and child, had given her the bacteria that created this bleeding, and that her response to it was exaggerated. She didn't have a good response. I felt she was at a higher risk, and she had to be much better care of her mouth. And she did. And we got down to no bleeding. So this business of vertical transmission and horizontal transmission is important, and we've got a big role to play in this. And if there's bleeding, it's serious, and we have to stop it. So yeah, it's very important discussing the transmission of bacteria.
So if somebody's really infected, what are our treatment options?
Jim, why don't you handle that one?
Okay. Well, you know, the world hasn't changed a lot. And the things I was taught in school and you were taught in school, the fundamental basics are the most important thing. Diagnose first. But the diagnosis we've been taught to do is we look for past disease. So have they built calculus? Do they have stain? That's already happened. It's unrelated to what's happening. We look for bone loss. That's past tense. Does it show risk? Yes, but it shows risk that happened, not risk that's happening, unless you have concomitant active infection. So how do you know if you have active infection? It's caused by bacteria, so you want to look for bacteria. So you have to disclose. I mean, that's the start of every hygiene visit. And if you're in my office and I see biofilm when I'm doing restorative dentistry, I'm disclosing and I'm going over how to take care of it. So you have to show them how to take care of their biofilm effectively before you pick up an instrument, a perio probe or a scaler of any sort. The next thing is that you have to measure the number of bleeding points. You can do that informally, or you can do like a PSR. But you also have to count numbers. Knowing that you have recording bleeding points doesn't matter. What's the score? Did you win by 5-3 or by 50-2? Do you have 50 bleeding points or do you have 6? There's a world of difference. Lorraine, you said someone had 30 and then they were up over 100. That's the difference. So the score counts. You do need to measure pockets. Again, that can be a PSR, it can be a full probing. And then you go on to decide what treatments you need. And let's assume you're going to do scaling and cleaning and remove the stain, but how do you kill the bacteria that's causing the infection? Because that's the key. So if you have a bladder infection, an ear infection, a chest infection, what do you want right away? It's not going to kill you. You're going to live. But in periodontal disease, we look at it and we say, well, you don't need an antibiotic. It's just a little bit of bleeding, or the antibiotics don't work. And the question is, why do we have that attitude? And we have the attitude because the delivery method we've used for antibiotics don't work. And they don't work because they don't deliver a high saliva level. And traditionally, oral antibiotics are going to deliver the antibiotic through the bloodstream, and it'll eventually leak into the saliva, but it gets in the crevicular fluid. And if it gets into the crevicular fluid, it helps with more advanced periodontal disease, but not breath odors and not mild to moderate perio, which is what 90% of our patients have. And if we look at the risk factors for perio, COVID, heart disease, obesity, diabetes, and we can go on with pregnancy. If you've got bleeding, maybe it's more serious than an ear infection or a bladder infection or a chest infection. Maybe it does warrant an antibiotic, particularly if you can deliver it the right way. And so I have a conflict of interest in talking about rinses, obviously, because I own shares in Orvital. But if you had a rash on your hand, wouldn't you prefer that you could apply a cream rather than taking the pills? And so if you can deliver the antibiotics without swallowing them and getting systemic effects, and deliver 3,000 to 4,000 times required to kill, or if you can have 2 to 3 times the minimum inhibitory concentration, and you can predictably kill the bacteria throughout the whole mouth, the tongue, the back of the throat, the tonsils, and subgingivally, you're going to get a better result. And when you talk about reinfecting, do you think about reinfecting yourself? Because we're doing subgingival cleaning, subgingival perio. Well, what happens if you didn't change their tongue and back of the throat, and then 6 weeks later, isn't that what happens? They reinfect themselves again. Mm-hmm. So there's breakdown in the way we've been looking at treating perio. And if you can add to it, other adjuncts. So we have the antibiotic in a cream form, and you can apply it locally, particularly for implants, breath. Carrie might mention that later, and for local perio. But these are things you need to do first, and then you can add your other adjuncts. So we think of things like over-the-counter rinses. Well, that's good, but which type of bacteria you're trying to kill? Are you killing all of them? Or have you got a decay problem? Do I have a perio problem? So pick your rinse to target. And if you're looking at decay, you're looking at CPC, or you're looking at chlorhexidine. And Crest Pro Health has CPC. Orvital has a CPC rinse that contains some xylitol as well. And we have a chlorhexidine rinse. Ours tends not to stain with its formulation. So they can target gram-positive decay-forming bacteria. And the decay-forming bacteria are the original ones that help to form the biofilm. So if you keep that down, it does help with perio, but it doesn't target perio. So if you've got breath or perio, gram-negative anaerobes, what's going to target them? Chlorine dioxide rinses. So we all know Closis as one that, if I mention it, and Smart Mouth has it as well, and we have CDLX. So how does that work? Well, it affects the mitochondria of gram-negative anaerobes, not gram-positives. So you're targeting a specific group, and it affects the ability of them to absorb the protein. And if they can't absorb the protein, they don't break down to volatile sulfur compounds, bad breath, and they don't thrive because they don't get energy. And Smart Mouth adds zinc. So if you add zinc, you're going to coat the outside of the bacteria, and you're not going to absorb the protein. So these are the chemical adjuncts you can add to the therapy of reducing the biofilm, killing it, stabilizing it. But 2 other areas, I don't know, maybe Lorraine and Beth, you want to mention these, perhaps lasers and the use of probiotics as means of stabilizing the area and keeping the biofilm healthy once you've transformed it to a healthy biofilm.
Mm-hmm. Yeah, I think one of the most important things to think about too is that so many of our patients have had an imbalanced, unhealthy biofilm for many, many, many years, and it takes months to shift that biofilm to a healthier level. So it's not just a one-sided approach, one size fits all. You know, we have to always be evaluating and reevaluating and looking at what we have to offer, but also having that DNA analysis gives us so much more important information about the overall bacterial load, which can help us with our treatment planning. So in our office, you know, we might do the Orovital antibiotic rinses initially, and then add in laser bacterial reduction. You know, I absolutely love the science behind this, and knowing that it is targeting those significant gram-negative anaerobes like PG, AA, TF, PI. So introduce that at a reevaluation when you still have some bleeding points, and then bring it up again at your consecutive 3-month period maintenance. So we're always working at shifting the biofilm. But one of the most important things that needs to be discussed with that patient too is their home care. And we as hygienists need to be so vigilant with helping to coach them on a continuous basis, using the assessment tools, helping them, you know, have the appropriate tool. They need to absolutely be doing something interdentally in order to continually be disrupting that biofilm. And, you know, periostat might be something we want to pull in. We might have to increase their frequency. And then again, as Jim mentioned, the oral probiotics to help in that maintenance phase. So there's so many things that we can do. And I think that's the value of education is what's new that I can do differently, because just doing your same old SRP and 3-month period maintenance isn't going to cut it.
Now, Beth, you've done a lot of lasers yourself, and you've used them for a long time. So you've seen changes in shifts in biofilm. You've seen this work, right? Like, it's great, right? Like, it's great.
Oh yeah, I think, and Lorraine, I think you hit the nail on the head with the points of the laser that you talked about. It's just that specificity of it. You're not just blasting through everything. It's specifically targeting that that gram-negative bacteria that Lorraine was. So I am a huge fan of laser, obviously.
Yeah, we've used it a lot. Like, we've used so many combinations. I think when you think about adding in testing, or you add in an air polish, or you add in something, you're not taking something else away. You're adding it as an additional resource, an additional tool in your toolbox. And I feel like whenever you add something, people are like, well, I have a laser, I can't use this, or I have an air polisher, I don't need to use that. No, it's a combination of tools that we have, and given your client's needs, giving their pathogen, giving their beliefs, giving all of the things that they are, you've got to be able to pull from more. And I think the truth of it is, as Anna Louise and I, with all the courses we give on the AAP, it's about getting people healthy. If your results are not working, go back, change your process, think of implementing something else, because all of these products work. If they're not working for you and for your clients, then figure out, is it the way you're using it, or is it you need to add something to it so it can work better? Would you agree with that, Anna Louise?
Oh, absolutely. You know, it all goes back to patient-focused, individualized care.
Individualized care.
Take the cookie cutter and treat everyone. And what works for one person doesn't work for another, because you've talked about it all of this whole hour about how individualized everyone's biofilm makeup is, and how we need to be able to see that. So when you're stumped and something's not working, then you have to, you know, adjust and reevaluate and try something else. And we've been presented here some wonderful, great education on ideas of where we can step up our practice, so that we can really help these people who are, you know, not only the out of control, like, you know, they've been coming in for regular therapy and they're still losing bone. It's not only those people, but we can now look at whole entire families, and how is this manifesting in even moderate and low grade perio conditions that make them more vulnerable for COVID, for sure.
Yeah,
I was gonna say, it's just trying to not pack everything into one appointment too. Because a lot of people think, oh, I have another thing to add. But the thing is, if you are going to practice differently and use all these different tools, then you are going to get better results. So you have to think differently, you have to practice differently, and be ready to implement change.
And the nice thing now is that Everybody can do testing. It's not just only, you know, Orbital offices, which was a bit of a fallacy for a while, and we've regrouped and everything. So anybody can do a test. It's not, you don't have to be a certified office. Anyone's able to access the testing and offer it to their clients. Check out other companies, other options, because it is such a vital tool, and it acts as a risk factor for you. It tells you what the risk is. So you look at the pathogen load, you look at their health history, you look at their bone level, you look at their family history. You see, you know, you just kind of have to put it all together to make a decision on whether you're going to treat or not to treat. And Lorraine and I and Jim, when we're all practicing, not every patient gets antibiotics. Not every patient needs that. We do a risk assessment. We make our decision. And if we're going to use the antibiotics that Jim talked about, they're a narrow spectrum. We're talking metronidazole and nystatin. We're talking metronidazole, amoxicillin, nystatin. Really bacteria that antibiotic that's going to target that bacteria, because we don't want to kill everything. We can't kill everything. As I've said, and you guys have probably heard me say before, I want all the kids to play nicely in the playground. We got to get rid of some of those bullies that are creating the problem, bring it down so then everybody can play nicely. And it doesn't happen the first time. You get rid of one bully, but then there's still some not so nice children there. So we got to kind of work and massage them. And maybe that's why we need the probiotics and we need the lasers and we need the creams or we need the over-the-counter Sorry. So anyway, rant over.
Pretending to be one of those kids with the laser gun, you know? That's the bully.
What's the learning curve like? Like if I wanted to implement the testing, what's the learning curve like as a dental hygienist? Like, do you have like, do you give like a manual? Do you give like what? So to help people start off and to understand what are they looking for, how it all works.
Yeah, we have videos, so very easy to do, and it really only takes 5 minutes to do a testing, ideally at the beginning of that hygiene appointment. But it is super simple. You're using a tongue swab, paper points, and you know, it's very, very easy to learn. And then we've got the guidance of the video.
Yeah, it doesn't take that long. Honestly, it's about 1.5 minutes from the time you do it. With Orbital, there's no cost to getting kits. You can request them and we'll send them to you, and you get billed when you send them in to us. So it's free shipping back and forth, which is nice. And it is pretty straightforward and simple. You're basically going to enter paper points like you're entering your probe in particular sites. You take them out and send the sample into us. So it's not even a concern for patients. There's no fear, there's no pain, there's nothing that comes across from that aspect with it. But that's a really good question.
Mm-hmm. No, I think it's great. I just think it's a really great thing that it amazes me that we're not taught this more in school, like even for dentists, because you're so passionate, Dr. Hyland, about it. And I know that a lot of people who are watching today or will be watching are wishing that their dentist was like you. And why aren't we trained that way at the beginning to show
Thank you.
the things, like these are the things that we need to look out for, like to be about preventative, you know, and not just, you know, restorative.
Well, when I work with the team, you all come out of school with the same skill. And so my assumption is you can all remove calculus and stain. I mean, I just assume that. I don't want to check the teeth and see, did you get rid of calculus and stain? If you didn't, you shouldn't be a hygienist, okay? So I hire for attitude and personality and the willingness to want to change and do better for the person you're taking care of. And when you do that, it transforms how you have a relationship with people. Mm-hmm. Honest to God, getting rid of gum disease is so easy. But you follow some of our directions, and we can give our patients a written guarantee. I'll tell them, if you use soft picks on the 3rd day, a written guarantee, money back, the bleeding will stop on the 3rd day. And on the 3rd day you stop using them, I guarantee it comes back. And then I'll tell them I can reduce the bleeding on probing, reduce your pockets overall by 80% in 2 weeks if you follow our directions. And if you can't deliver that to your patients consistently, the question is why? And it's not, as they say, rocket science. It's control the biofilm and kill the pathogens, and then keep on the biofilm control. That's the patient's problem. That's not our problem. And if we do therapy to try and move the bacteria around but don't kill them and change the biofilm, they never get better. That's why 80% of patients are still bleeding.
And this all comes back to making sure that we document everything that we do. You know,
Oh, yeah.
Lorraine talked about some different options and some indices. And, you know, I know, and I'm sure in your course, Anna Louise, when you do documentation, and Beth and I with our process of care course, we talk about using all of these different indices in order to bring it together so you can show patients it's improved or it hasn't improved. And, you know, we have to do our periodontal charting. I know Dr. Hyland mentioned, you know, PSR or periodontal charting. We do periodontal charting once we see they have infection. It has to be done. It's not an
Right.
and or. This PSR is really a periodontal screening and recording, but we need our full periodontal charting, including 6-site bleeding on probing, our recession, our cals. The list we know is very long and drawn and all is so important. So.
So right at people's fingertips.
I use the PSR myself as a quick screening tool, and I'm using it not to record the depth of pockets per se, but is there bleeding on probing, but also is there bleeding while I'm wiping the probe from site to site, as opposed to lifting it up and down. I'm wiping, because that's a bleeding index as well. And these are things you have to assess, that pocket and bleeding on buccal and lingual tissues as part of your therapy, because the soft picks do between the teeth. They don't do buccal and lingual tissues.
Right.
Well,
Well,
I
I
was thinking
do.
about another story that
That you have offered not only some awesome education today, but also like to make available for layered learning activities, to go in and watch these videos and just see how effective and simple it is for us to implement into our program, and for us to be able to carefully select the clients that we're going to step out and give it a whirl on, right?
Yeah.
Thank you.
Yeah, and so we will send out a follow-up email as well to anyone who's on or who watches it afterwards. And so we'll direct you to the videos and to webinars and articles. Was there another slide that you wanted to share, or was that, there was those two?
No, but
Okay.
I would like to just touch on what Anna Louise said as far as another option for helping clients, and what I find so helpful and I'm really passionate about it is halitosis, because I feel like halitosis is sort of the elephant in the room and nobody knows what to say. We all have heard people, maybe it wasn't you, but someone that has said, oh, that's a double masker, or I need to put things up my nose so I don't breathe in their perio breath. I'm on the airport and I had to sit beside someone with perio breath. But we don't address it, and we don't know what to look for, and we don't have necessarily the tools in our toolbox that will help with it. One of the biggest things I found so helpful was looking at the pathogenic makeup for these halitosis patients, because many of these clients are so neurotic that they brush, they floss, they do everything they can, they control their diet the best that they can, they drink all the things that they're supposed to. But it's their pathogenic load and the amount of bacteria that are there that has to be broken down. And so this has been a really great adjunct. And that's why we offer with Orvito the 2 different types of testing. So you have your typical periodontal patient, you've got your medical history risk patient that you would do DNA testing for. If you have a halitosis patient, that's when Lorraine and I and Jim usually will shift our focus to gram stain, because it gives me a localized spot of where all those concerns are. So it gives me a report on the tongue, a report on the back of the throat, it gives me a report on the teeth. Because sometimes what you're gonna find is that the pathogens are not around the teeth, because the patient has done a phenomenal job at cleaning that. It's the throat and it's the tongue. And so you clean their teeth, they clean their teeth, they get that all cleaned, but then the bacteria just sort of jump back and forth. And that's why often a lot of our site-specific areas or different things we're doing around the teeth don't help with halitosis. We have to clear the whole oral environment. And so that's really kind of been a unique passion of mine that I've developed in the last 12 years with working with Orvito. And it's really been such an amazing opportunity to help some clients that are really, truly suffering. And people will say to us, oh, I don't have any of those clients in my practice. Well, you do, they just don't know how to ask you because they don't think that you're approachable. And so part of what we offer for some of our clinics too is marketing and brochures that you can leave out and you can kind of have them reach out, and it's a neat way to connect with people. It's a great additional service to offer. And it really is sort of a untapped market, and it truly goes after the heart for me. I just love helping them, honestly.
Confidence builder.
Yeah, and I think everybody here's had patients that have suffered from tonsillitis, right? Like those little tonsil pimple stones. And what do? How do you help them? Right? And so we have to figure out the different causes. We've got to look at the bacterial load. We've got to make sure if they suffer from those that we're recommending that they rinse. They're not just swishing it around, but they're actually gargling it. And watching people rinse, I do find that kind of fascinating. You give them their pre-procedure rinse and you watch them swish for 2 seconds and they spit it out. It didn't go in between their teeth. It didn't even touch the back of their throat. It barely hit their lips and it was out of their mouth. So, you know, it seems like a simple procedure, like, hey, go home and brush your teeth. How many clients brush their teeth properly? Well, how many clients rinse properly? So again, if we're recommending rinsing, watching those behaviors, this is part of the observational data that I collect from my clients. I'm always watching them and I have these interesting stats that I pull from, but you know, it's neat to see all this stuff and to make sure that if you're recommending a product like a mouthwash, they understand how to use it. So anyways, I know you guys all laugh at me. I'm thinking it's good. Rant over.
It's very true. It's very true. Watching people rinse, all of a sudden they've expectorated before it even, like, did it even get warm?
Yeah.
Right?
Or they rinse it with water afterwards, and there goes all the benefit.
Yeah,
I know.
It's happened before too.
I know. It's pretty fascinating to watch those sorts of things. And so it's just, you know, looking at testing and offering this, it's just another adjunct to your therapy, to your full assessment, to your data gathering. And it's a neat way to collaborate with people and to bring it all together because it really does help your clients. And you can connect with cardiologists, you can connect with medical doctors, you can connect with nutritionists. There's lots of options out there for you.
Share the reports. Yeah, you can share the reports. And that's what we need to be doing more of. To help anybody who's watched the webinar or will be watching it recorded, we are offering $25 off our testing for 1 DNA or 1 gram stain. So if you're in Canada, the usual price is about $112. So it'll be $87. If you're in the US, the price is $99 US. It'll be $74 US. So just mention RDHU, and we'll give you that $25 discount on a test that you send to us, even if you're a certified clinic or if you're somebody that wants to get started with it. So that's an offer we have for you for listening today.
That's great. I was coaching somebody for the portfolio for January, and one of the dental hygienists that I was helping does the Orovital system on her own. So she said that, you know, she went ahead, like the dentist didn't want to go ahead with her. And so I thought that was very impressive that she actually did that on her own, and she's loving it. So I just thought I'd share that with you. But hopefully you get the team on board too. It's always better when you have the team on board. But again, I think just having these things, like I'm so into marketing and I'm always looking at people that send us postcards at home and what have you, and everyone has the same message. When you can really start to talk about overall health, you know, bad breath, you know, we can help you with your bad breath. We can help prevent, like, these are the things that, or talk about COVID and trying to keep down the bacterial load. Like, these are things that right now, that should be our messaging, not, you know, you can have a free toothbrush when you're a new patient, or you're going to have free whitening. I'm still receiving these and it's amazing. And I see them pop up on my Facebook, and you can't have the same messaging and it can't be the same. So thank you so much for inspiring us here today and sharing your knowledge. I always get so pumped up after I spend time with you, all of you. Even if
it's been a pleasure for us too. It really has.
Thank you. All right. So is that it for everybody?
Yes.
Thank you. That was excellent. Great learning.
Thank you for joining us, and I'm sorry for those who are watching it later. And it was a bit of a hectic hour trying to get this going, and so we apologize. It was totally out of our control, and I'm happy for those who are on with us, and happy for those who are watching this after. And technology isn't always our friend, but tomorrow will be another new day. We just keep going.
If you want more, hold on. If you want more information on testing, just email us at info@oravital, ORAVITAL.com, And just let us know you found us from the RDH view. And like I said, we can facilitate getting you kits if you want, or you just want to talk to Lorraine or myself a little bit more personally. We're happy to, the truth of it is we just want to help you. We want to help your clients. That is really the mission, and that's the heart behind the company. So, you know, thank you very much. I'm happy to be here as part of the view, but also as part of Aura Vital. So thank you, ladies, for having us on here. It's been awesome again.
Thank you. All right, take care, everybody.
Bye-bye.
Bye.
Bye.